Okay, let's get started. Welcome everyone again to our webinar series on foundations of colorectal cancer screening and care for health educators and community health workers. This is a webinar series that will be taking place on Tuesdays today and also on next Tuesday at the same time. On today's session, we will be focusing on colorectal cancer prevention, screening and intervention in health centers serving medically underserved populations. Just a few reminders to everyone that you're muted upon entry. Please make sure that you engage in the chat if you'd like to also participate throughout today's questions and case study section. This meeting is also being recorded. And please make sure that you raise your virtual hand if you would like your line to also be unmuted. As we do in all of our sessions, we always encourage all of our participants to also participate verbally if you're able to. The slides, again, will be sent to you all via email after today's session and the recording link. So for today's speaker, we'll be having our awesome Dr. Kevin Lombardi. He is the Director of Research, Policy, and Health Promotion at the National Center for Health and Public Housing. And here you have just a brief overview about his background, how he has served as Director of Research for quite some time here at North American Management and CHWs. He also has experience in integrating clinical medicine, public health, and systems evaluation to enhance primary care quality, workforce development, and policy across the U.S. safety net. He also directs national assessments and program evaluations and has also published in major journals here in the U.S. And my name is Frida Pineda. I am the teaching manager, and with me I also have my colleague, our health communications and research analyst, Ola Jimokeladipo. We will be co-moderating and basically handling the logistics for today's webinar. So without further ado, I'll pass it on to Dr. Kevin Lombardi to get us started with our learning objectives.
Hi, everyone. Welcome, and excuse the awful headshot of me. Uh, anyway, I really want everyone to today to get a good understanding of what colorectal cancer is, from a bunch of different perspectives. But in particular, how it develops, what it looks like. I want there to be a picture in your mind of all of those things. Now why? First of all, jump in the chat, tell me what you do. Uh, this session is targeted at folks that educate and work with individuals to get their screening who are getting screening, CHWs, behavioral health folks, case managers. In order to convince folks to get the screening, you need to have a good understanding of how the disease works. And I'd like to take you from micro to macro. From at the molecular level, how this condition actually develops, what it looks like, what it feels like, to at the macro level and at the population level, why folks aren't getting their screening and how we can then convince them to do it. Uh, Colonoscopies aren't fun. They're not something that you typically do on a Sunday afternoon if you have extra free time. Some people hate them. They're scared of them. I know quite a few folks that have more risk factors than you can point a stick at that still refuse to do it. For folks like that, there are alternatives. There are blood tests now. There's fecal occult blood tests as well. But colonoscopy is still the gold standard. In that, for the fecal blood occult blood tests and the blood tests, their accuracy is not approaching that of the colonoscopy. Colonoscopy is the gold standard. And for folks who do that testing, if they're positive, well, the next step is a colonoscopy. So we're going to end up here eventually. And being able to educate folks about why they need to get it and to get them to understand why it's important and why we're doing this is an important part of doing that screening. And I can't tell you how many folks I've seen inpatient at the hospital who are late stage with metastatic cancer that's in the liver or in the brain because they did not want to do their screening. It happens. We can avoid those cases if we get better at educating folks and empower them with information. But we need to be able to talk about this in sort of a multilingual way. And by lingual, I don't necessarily mean different languages in the traditional sense, but being able to describe it in different ways so that different folks can understand and you can convince them. There's a lot of marketing that's involved in healthcare. And we're often trying to sell people things that are uncomfortable or that they don't understand. So please jump in the chat. Let me see what you guys do. And oh, we've got some DC people here. We're based in Northern Virginia. Weather's been great lately, hasn't it? Jump in the chat. Tell me what you do, who you serve, where you serve. FQAC in Maine. I wonder if the water's still cold up there. Beautiful summers up there in Maine. It is, yeah. Sometimes in the 50s, it'll kill you up there. MedStar Washington. Oh, I did some training there in medical school. Great facility. Right near the VA. Beautiful place. Um, Oklahoma. Cool. We got some regional diversity here. There we go. Fabulous. Okay. Keep doing it. I want to see where all you guys come from. A lot of DC people today. Fabulous. So let's go on to it. I'm going to start with some pathophysiology, and then we're going to talk about some epidemiology, and then we're going to talk about a case study. And if I got one more alliteration, it would be one more ology, it would be an alliteration. Next slide, please. Okay, so how does this stuff even develop? What does colorectal cancer come from? So picture your healthy digestive parenchyma. It's smooth, it's beautiful, it has you can see the blood vessels, but not too many of them. It is consistent, it is healthy, and the cells are dividing normally. Now, throughout your body, your cells divide at different rates. And in your skin, very quick division. That's because your skin cells are constantly sloughing off. Your body needs to be able to replace them, or your skin would just erode, and it wouldn't protect your body. If for cells like in your bones or nerve cells, there's very little division because it's not needed. Those cells don't need to be replaced as often, and they are confined physically. So if they were to grow quickly, it would cause a compartment to grow, or would cause pressure to grow in that particular area. The body balances this with certain genes that act as gatekeepers for cell division. Now, those genes are in the nucleus in every cell in your body. And throughout your life, you are exposed to things that mutate or can mutate the DNA. A good example of some is things like smoking. For example, smoking exposes you to all of these environmental toxins that mutate the DNA or the RNA or both. And what does that actually do? Or why does that actually happen? Well, it exposes it to a chemical that disrupts the replication of the DNA and the RNA, so that those base pairs that code for a very specific set of proteins get disrupted a little bit. Now, over a lifetime of exposing yourself to toxins, sometimes those mutations get broken in just the right spot where they disrupt the system that keeps the cells dividing normally. Now, things that do that are things like smoking, of course, but also other things as well. Red meat is a known mutator as well through inflammation. Things that cause inflammation in the body can have the potential to disrupt the DNA in the nucleus of the cell. Now, the thing with the colon is it is exposed to everything you put in your body, everything you eat. So typically, the diet that you have is going to be the major risk factor that determines your risk. Things like lots of red meat, not having lots of vegetables and not having a balanced diet exposes your colon parenchyma more and more to these inflammatory molecules that put pressure on that DNA and lead to the accumulation of mutations. Accumulation of mutations. I like the way that sounds. So, how does this lead to colon cancer? And it's not just one mutation that does it. It's many over a lifetime. So I want you to look at this image here. On the left, we have a normal intestinal epithelium. Now, epithelial cells are a type of cell, a progenitor cell that, like your skin is epithelial, in your GI tract is epithelial as well. And these are quickly dividing cells, but they are controlled by set gatekeeper genes. Oh, thanks for the arrow. The normal intestinal epithelium here. Now, on the far left, these are cells that are dividing when they need to. They're dividing on a set schedule. They're dividing when there's damage. They're dividing when they need to. Now, over time, a lifetime of, say, eating lots of red meat, not eating lots of vegetables and fruits, and not having a balanced diet, it exposes a hypothetical individual to a lot of inflammation. And over time, those mutations build up. Now, most mutations, not an issue, right? But if they are in a specific area, that's where we start to see tumor growth. And I want you to look at if I could get another arrow on the second one, the KRAS and BRAF mutations to the left, a little more. My left. Sorry. Uh, you can see on the second line of cells KRAS and BRAF mutations. KRAS and BRAF are two tumor suppressor genes. Now, these are genes that are gatekeepers for cell division. And when it's time for the cell to divide, they switch on like a light switch, and then the cell divides. Now, over a lifetime of exposure to inflammatory molecules, of say, toxins such as from tobacco smoke or to alcohol, there's a chance of getting a mutation in one of those. And when that mutation happens, they're switched on and they're stuck on. And when that happens, the cells start growing uncontrollably. At times, they can grow to exceed their blood supply. Now, if we keep going to the left, as you can see, there is a little tumor here. Now, typically, if there's an initial mutation, there will be a growth, a benign tumor growth. Now, that's a tumor that is restricted by its blood supply. There's only so think of your blood as being like your blood vessels as being like roads in a town or a highway. There's only so many cars you can put on the highway. There's only so many blood cells that you can put in a blood vessel. And typically that would restrict a benign growth from growing any further. Why? It can't get any more nutrients. It can't get any more oxygen. As a result, it's sort of stuck in that benign phase. But over time, as the individual is exposed to more inflammatory molecules, exposed to more time, and exposed to more toxins, there can be additional mutations. And I've got a list over on the left. The Bax mutation, TP53 mutation in particular, those are related to something called angiogenesis. And that's the ability of a tissue to create more blood vessels. Now, when you've got a mutation that is putting that cell division switch on and sticking it on, and there's an additional mutation that is bringing in more blood vessels, literally growing them in the area, that's when we start to go from a benign growth to something that's potentially metastatic. And why is that? because now the tumor has as much blood as it wants and it can grow as much as it wants. Now, we're going to look at pictures in a moment, but in particular, those tumors can get huge. They can get huge to the point where they're literally obstructing the GI tract. Now, that's when we are in our carcinoma phase here. Now, if you look at carcinoma to metastasis, you can see those cells sloughing off and going into the blood vessels. That's when we get to the point where we can have metastasis. And what's the change that makes that metastasis possible? Now, we started with a normal cell, normal cells in the colon. After some initial mutations, well, those cells they're stuck in the growth phase, so they will grow as much as the blood supply will let them grow. Then, an additional set of mutations allows that tissue to grow its own blood supply. So it got as much blood as it needs, so it will continue to grow. But the cells are still stuck there in that area. The next change is on the adhesion molecules, the molecules that stick the cells together. They're like little locks, or if you've ever knitted, they're kind of knitted together. Uh, Additional mutations can lead to those being erased. And as a result, the cells are slippery. And when they're slippery, they can come right off the tumor, they can go into the blood, and then they can go anywhere else in the body. Now, typically with colorectal cancer, we see metastasis in a specific correlation, in particular the liver, the lungs, and the brain. Those are the first areas where they tend to show up. And the reason is that those are the areas that are most downstream from the colon, from a blood supply perspective. Uh, when your blood goes through your GI tract, the next place it goes is your liver. And downstream from that are your lungs and your brain. So once those cells are liberated and they can leave the tumor, there's nothing sticking them there anymore. The rest of the body is open game for the cancer, and it can spread everywhere. That's when we have metastasis. That is our late stage cancer, and those are our very serious cases. This happens over a lifetime. Now, there are set things that make it more likely or less likely that that'll happen. Fide Jamoke, can you think of something that makes it less likely or more likely that someone accumulates mutations in their colon and
Um,
progresses towards cancer?
I can think about something that could be less likely would be changes into a healthy lifestyle. Like the diet has a big plays a big role into that.
Why? Why do I care about diet? Why does diet matter?
Because so many of the different foods that are out there, they're highly processed, and
Mm-hmm.
those can cause inflammation, make
Nailed
inflammation
it.
worse in the body. Yeah.
Inflammation. Inflammation is the enemy. Because inflammation helps those mutations accumulate. The less you are exposed to inflammatory food, like processed foods in particular, the less your colon parenchyma is going to be exposed to inflammation, the less it's going to mutate. But there's also a counterbalance that I didn't mention. Uh, the way that inflammation drives the mutation is through free radicals, and it's a really scary name for a scary thing, but they are extra electrons that or excuse me, lack of electrons that sort of destabilize the molecules around them. And we can balance that though and add extra electrons to that and keep a balance between the inflammation and non-inflammation with things like fresh fruits and vegetables. In particular, things like vitamin C. Vitamin C is amazing for balancing off inflammation. It takes those inflammatory molecules that are sort of pulling at the different parts of the parenchyma. They're pulling at the DNA and destabilizing it, and it balances it off. So diet, 100%. The other thing you mentioned, or you may not have mentioned, you may have mentioned it, is exercise. When someone physically exercises a lot, in particular cardiovascular exercise, running, biking, swimming, that helps to lower the overall inflammation burden throughout the body. And in fact, for those who regularly engage in cardiovascular exercise, they can reduce their overall lifetime risk of cancer by 20%, in particular colorectal cancer. So these are the main things. This is how this sort of develops. This is how it works. And I want you to sort of keep this picture in your mind when you're talking about patients, so you can explain sort of what drives this and why. Next slide, please. Now let's go through the recommendations here. You may want to take your arrows off. It seems like they stick. Let's look through the recommendations. Now, you'll hear a lot about different modalities available for colorectal cancer screening. Um, Colonoscopy is the gold standard, and by gold standard, I mean it identifies the most cases accurately. However, it's invasive, right? It's uncomfortable, and folks don't like it. There are other modalities available, fecal occult tests and direct blood tests now as well. The fecal test they can take home to do, they can do it through the mail. It's very convenient. However, if those come back positive, a colonoscopy is necessary for diagnosis. So regardless, we need to be prepared to encourage folks towards that. The U.S. Preventative Task Force recommends screening for colorectal cancer in all adults aged 50 to 75 years, regardless of risk factors. There is a new recommendation for individuals age 45 to 49. It's less, they give that a B. So it's not as strong a recommendation, meaning it's not as supported by medical evidence, but a B is a significant rating and it's something that's recommended. Where we get into the gray area is with older folks, age 76 to 85. That's when the risk of the balance between risk and benefit is less clear. Now, no diagnostic test is perfect. There are false positives, there are false negatives, and in particular with colonoscopy, there are risks of injury as well, risks of perforation, and so forth. At the for individuals aged 76 to 85, it's really usually based on the individual risk factors for that patient and the conversation the clinician has with the patient. Things that make you more likely to recommend it are things like a family history, more than two relatives that have had colorectal cancer, first degree or second degree relatives, and the patient's history of cancer screening at all, if they have had it at all. If I'm looking at someone who's 76 years old and they've had a uncle and their father both died of colorectal cancer, I would tend towards yes. If I see someone who's 76, 77, and who has never been screened before, that's a yes. But if I have someone who is in their 80s, has had their colonoscopies consistently through their life, and they've always been cleaned, then that's less of a benefit and more of a risk. So when you get down to the individuals who are older age, it's more based on individual medical history. It's more based on the clinician's recommendations and the conversation between clinician and patient. Next slide, please. Now, what does this stuff actually look like? Here are some feeds from actual colonoscopies, and I want to go through the different images and kind of point at the areas I was talking about earlier. I want you to take a look at frames A in the top left, B right next to it, H in the bottom, and I. right next to it. And there's some arrows that are pointing at the areas that I really want you to focus on and take a look at. In A, you can see the polyp very clearly. And if you look at it, you'll notice that the color changes towards the edge where that bubble is. Um, and that is rich with blood vessels. That's what I was talking about earlier, the angiogenesis, the ability of the of back, please. The ability of the tumor to basically recruit blood vessels. That those blood vessels is what allowed that polyp to grow more. You can see there that that polyp is partially occluding the lumen as well. And given that it has a blood vessel intrusion there, there's a possibility that it could potentially block the lumen and create a GI block as well. When you look at B as well, you can look closely. You can see those blood spider vessels, those vessels spidering throughout the tumor and both facilitating its growth, but also giving those cells an opportunity to get into the rest of the body. They are highways that those commuter cells can jump on and head to the liver, head to the lung, and head to the brain. And that's where we have metastases that are difficult to treat, particularly in the brain and the lung, very difficult to treat. So our goal is to catch it before then. So a patient like this will require multiple biopsies to be taken. What they do is they take a piece, or they will take that polyp out during the colonoscopy. They will send it to pathology, and they will look at it under a slide. They'll put chemicals on it to see sort of what particular stage the cancer is, and or if it is at all, and give us details about treatment. Next slide, please. And here's what it looks like when it's normal. I guess I should have started with this, but this is normal, beautiful parenchyma. This is how it looks with no mutation at all. And look at the difference here. The vessels are consistent, they are smooth, and there's no polyps, no masses extruding into the lumen. So this is what you want to see. So this is someone you want to continue screening. This is at a regular intervals, and someone you want to continue providing public health advice, and you want to look at what they're doing right and support it. When engaging in patient education, there's a when I think of people who do this well and people who sort of do it in a mediocre way. Um, a mediocre way is to just sort of give the education. A colon cancer is XYZ. This is what increases your risk. This is what decreases your risk. This is what you can do that you're not doing. I like to take a more personalized approach and to focus on the things that the patient is doing right. Are they exercising regularly? Are they eating lots of fruits and vegetables? Look at the things that they're already doing that they are good at and build on top of it. When you see the patient, things that the patient is are doing that are correct, that are good, that are pro healthy healthy colon, pro healthy health, pro good health, uh, you find the things that you can build off of. If someone is good at exercising, they're good at managing their diet, there are certain strengths there that you can build upon and add more factors that allow the patient to further reduce their risk and to keep their colon looking more like this and less like the last slide. Next slide, please. And just a picture to show you how the colonoscopy actually looks. It is a camera that goes through the rectum and crawls up the colon and visualizes each section of the colon slowly. Typically, the GI doctor will take picture. They take pictures that go into the medical records, and if you go into a patient's record, you can literally pull this stuff out and see it. During the exam, they will perform a polyp removal if they see a polyp. So colonoscopy isn't just screening. It can be active removal of a polyp as well. Something to mention to the patients as well. If they see something, they will be able to take it out. Next slide, please. The algorithm here is mostly for your reference and less for us to go over here. But the things to note here for folks less than 50 years old, without a family history or without other factors, the recommendation is no screening. For those who are less than age 50 who have a positive family history, in particular, two or more first degree relatives um, uh, who had colon cancer at less than 60 years, we would recommend it for those individuals. When you're older than 50, doesn't matter if you have a family history. That's when we start screening proactively. Next slide, please. Now let's take a look at why people do this and why they don't, and get some insight into what we can say, what we can do to convince them to get their colonoscopy. Um, this is from research that I did on HRSA's Health Center Patient Survey. It looks at folks that go to FQHCs, and it essentially looked at questions as to why they have or why they have not received their colonoscopy. Next slide, please. And next after that. The table is mostly for reference. So let's look at the most common reasons for not obtaining screening among our public housing primary care patients. Those are our PHPCs, our FQHCs that serve residents of public housing, and the reasons for obtaining their cancer screening, why they didn't do it, and why they did do it, per what the patient says. Next slide, please. And there's some lower hanging fruit here. I was surprised when I saw this. Surprised but not surprised. The most common reason that people did not get their colon cancer screening is they had no reason slash they never thought about it. These are individuals where there is a knowledge or motivation gap present. This is our low-hanging fruit. This is why it's important at clinic appointments, at CHW visits, even for things unrelated, at behavioral health appointments, everywhere. We should be asking people about colorectal cancer and screening and if they have gotten it or not. And we should push those referrals aggressively when we can. The next one, next slide, at 26.8%, didn't even know they needed the test. That's a clear knowledge gap, and that's on us, right? These are patients that literally did not know. So if you take 100 people, 26.8% didn't even know they needed the test. And the last one was a lot smaller than I expected. At only, next slide, please. At only 8.8% did not receive their colonoscopy because they thought it was too painful, unpleasant, or embarrassing. So what does this all tell us when we put this together? Um, what I see is that patients who aren't getting their colonoscopy or aren't getting their colorectal screening are not necessarily doing it because they don't want to, because they think it's uncomfortable, or because they think it's unpleasant, but because of a knowledge gap. That's a good thing and a bad thing. The bad thing, of course, is that these patients don't have the information. The good thing is that's a much easier thing to fix than convincing someone who doesn't want to get a test. Uh, so the emphasis is on us to educate our patients and to make sure they know that this is not only necessary, but it's a priority. Next slide, please. For those who are getting their colonoscopies on time, they're doing it for set reasons. 62.5% are doing it because it's part of their routine exam. They are taking their advice from you, from their providers, and they are getting their colonoscopy. Number two is where I get nervous. It's because of a problem. Out of 100 people, 21 of them are getting their colonoscopy because they have an issue, a GI block, a GI bleed. Of note, if you remember those polyps, they had all of those blood vessels on sort of the exterior, the angiomas, the redness that's climbing throughout the polyps. Well, when there's a lot of blood vessels in an area, it's easy for it to bleed. And oftentimes, when we're identifying these outside of a routine exam. We're identifying them because of a GI bleed. The patient is coming in because they're either lightheaded, they're anemic, or they're having very, very dark black stools. The dark black stools are the ones that indicate that there's a GI bleed in that area. Now, typically, when patients are talking about stool color, when we have bright red stool or blood in the stool, like clearly red blood, that tends toward rectal bleed and lower GI bleed. For bleeds that are happening in the colon, the blood is in the GI tract enough that it turns black, and that's sort of the iron sort of rusting. So the stools would not be red, they would be dark black. So when patients are talking about their stools and they mention that color, that is a red flag that tells you that that patient needs to have their blood screened and they need a colonoscopy. Two slides forward, please.
Uh, Kevin, we had a question really quickly from
Oh,
Judy.
some talking points for the reasons for not obtaining colon cancer screening. Well, I'll tell you, I've got a couple, and I'll tell you what my hypotheses were before the research and what they were afterwards. From dealing with resistant patients, and frankly, from having a resistant father, and resistant relatives, who don't follow dietary recommendations. And from dealing with a lot of patients like that, my assumption was that for folks where we miss this, it's because of they're not getting their screening because they don't want it. Because the screening is uncomfortable, it's a burden, or they are just sort of, see no evil, hear no evil, that they'd rather not think about it. That was my assumption. When I did the research, I found that 8.8% of individuals were identifying that as the reason that they didn't. A much larger group, up to 60% or close to 60% of folks that had not received their colon cancer screening, it was because they just did not know. Period. That was a big surprise for me because one, I mean, we're not seeing the patients. They don't know, and we're not having the conversation with them, so we're not having exposure to them. Oftentimes, what we see kind of imply it creates a bias. If we're having a lot of conversations with resistant patients, we may think that's a bigger piece of the pie than it actually is. What the data tells us is that individuals who aren't getting this are not getting it because they don't know they need it or they don't think it's a priority. And that's a knowledge gap. And why is that happening? Well, there's a couple reasons that are sort of systemic. One, appropriate and regular clinic primary care. Many individuals do not receive their regular primary care and do not have an opportunity for regular conversations with their clinicians. Two, uh, conversations about screening are typically limited to the primary care and adjacent realms. We should be talking about colon cancer screening and cancer screening in general, and that goes for breast cancer screening, uh, cervical cancer screening, and so forth in other domains as well. In particular, for those of you who are CHWs and are working with individuals for other things, and I mean the whole basket. Put this on your checklist to mention this. Do not assume that these conversations are being held in the clinic room. It's 15 minutes. They don't have a lot of time with their provider, with their nurse practitioner, their physician, or what have you. So oftentimes these conversations, if they're being had, are very short. Now, if there's an individual who goes to their clinic appointment and their physician says, "Have you had your colon cancer screening?" and they have a 2-minute conversation with them, that's not much. That's not enough to really impart knowledge on the patient. The patient might say, "Yeah, yeah, yeah," and the conversation doesn't go further, or in many cases, the conversation just doesn't happen. So making sure that conversation happens, but not just to check the box, because checking the box only helps the medical record. It doesn't help the patient. We need to be diagnosing the knowledge gaps. Um, so for those of you who have high surface area with patients conversationally in behavioral health, in community health, and in case management, nurses, uh, you're the individuals that have the power to have those conversations and the skills to have the conversations as well in sort of a more anecdotal and more patient accessible way. Uh, in my opinion, you are the road to making that gap smaller, so that patients know, they understand, and they can prioritize. And for resistant patients, I keep it focused on quality of life and family. If you know a patient and you've seen them, or your CHW working with them, talk about their families, talking about being able to see their grandchildren, talk about being able to be age in a healthy way. And these are ways to motivate people to obtain the colorectal cancer screening. But it's really on an individual basis. If you know your patient, if you're present in the conversation, you'll be able to find those hooks in order to get the individual to be more likely to have the test. It's as much education as it is marketing as well. You're trying to push the test in a way that's very similar to an advertisement. Um, so I hope that answered your question, Judy. I want to go briefly into a case study, or spend the rest of the time on a case study about Mr. Rossi, who doesn't think he needs one. Um, Mr. Rossi is a 57-year-old man who presents for a wellness exam at his health center. He has a past medical history of hypertension and high cholesterol. Past medical records indicate that Mr. Rossi has a history of missing his appointments, poor compliance with his medication, and switching doctors. He has been unhoused in the past, and his current housing status is unknown. His record also notes that his stated reason for his appointment today is to refill his blood pressure medication. The patient undergoes a standard intake, including vitals and an SDOH screener. The results are as follows. Blood pressure today, 178 over 98. Weight is 145 pounds. Heart rate, 92. Respirations, 18. A review of Mr. Rossi's medical records indicates the following. Now, in 2022, the last time we saw him, his blood pressure was 138 over 98. Heart rate was 60. Respirations were 18. And weight was 210 pounds. We have an A1C at record at 5.2, which is pretty good. Prescribed medications. He takes a thiazide diuretic, and he takes a thiazide, and he takes a depression medication, citalopram. Okay. Any red flags here? Audience, what do you think? Any red flags here? Anything make you think colorectal cancer risk? Oh, Kathleen, you were the first. Weight loss. What, maybe he's just jogging. What do you mean weight loss? Why does that matter? Kathleen, are you available to tell us why I should care about this weight loss? Maybe he's just getting ready for the beach.
Hello.
Kathleen, what do you think? Is Mr. Rossi getting summer ready, or is there something else going on potentially here?
I mean, it looks like something else could be going on for sure, especially since his blood pressure has spiked as well. But the weight loss to me is pretty significant.
100%. Now, what's weight loss have to do with cancer? Are they
Well, I
connected?
believe, yes, yeah, people who, yes, they are.
100%. So when I see weight loss, and sorry to put you on the spot here,
That's okay.
and thank you. So when I see weight loss, are you thinking someone might have a polyp or someone might have a more advanced cancer that we may have missed?
My guess it would be more advanced.
100%. Yeah. And thank you. Kathleen, can you tell us who you serve and how you serve them and where you serve?
Greater Portland Health in Portland, Maine, and it's an FQHC.
Oh, fabulous. We've got Mainers here. I love Maine. I'm from
Yeah.
love Mainers. I'm from Massachusetts, so we're gonna keep your beaches and your communities nice and busy and crowded this summer,
Yes, for
with our
sure.
lovely accents and, of course, polite behavior. Um, so thank you for that. Yes, weight is a huge thing. If you see a patient that has gone from 210 and to 145, even if they've got washboard abs, that's a red flag. Now, for the pathophysiology of why this happens, we don't really know so much. It's more disruption of metabolic rhythm and so forth. It's multimodal why folks lose their weight. But we're looking at it's close to 65 pounds here. And that's a major weight loss. It's been years, it's been 4 years, but as soon as you see that, you should be thinking cancer risk, and you should be thinking, has this patient has it had their screening? First thing that should come to mind. So you nailed it. Um, the other thing is the blood pressure. So, he mentioned refilling his medication, and I see he has a thiazide diuretic he takes. So I see that 178 over 98, and I'm thinking, is he not taking it? And he's just taking half the pill, or is it being improperly treated, and does he need a second line agent added? That's what I'm thinking of. As far as other red flags here, I want to sort of emphasize that he has a history of missing appointments. Um, we haven't seen him in 4 years. He just lost some weight. What happens if we don't see him in another 4 years? We might not see him at all. In particular, with this weight loss and the risks here, this is a patient that needs to be brought into the fold, and I will say gently brought into the fold. Don't guilt him, don't scare him, encourage him. And I'll sort of emphasize and underline encourage him. And I'll say, pitch it like an investment. Mr. Ross is 57 years old. My guess is he wants to be around at 77 years old. Maybe he's got kids he might have grandkids. Maybe he's, I don't know. Maybe he is getting ready for the beach and wants to retire. So pitch the quality of life, and the importance of primary care and screening in facilitating that. It is an investment in their future, and that should be sort of a major emphasis of your conversation with them. Next slide, please. And we're not going to make it all the way through the case study, but we will pick it up next time. Now, we give him a non-medical needs screener to sort of as a baseline screener that's given at the FQHCs. Non-medical needs are missed all the time. A patient's non-medical needs can drive their medical needs more than actual medical pathophysiology more. This is stuff we need to know. If your facility isn't doing a screener like this, add it. Easy to do. They can do it at intake. It gives key information that otherwise takes a lot of time to ask. And I mean, like you can spend a half hour asking all these questions to a patient. It could take longer. It's just not feasible in sort of a normal timeline. So these are a great thing to add. Bottom left, I've got the Well RX questionnaire as well as research that validates it and tells you how to integrate it. So if it's something you don't have that you're interested in doing, put it in front of the folks that need to see it and make it happen at your health center, because it's a driver of efficiency and it's a driver of safety. And we're all living our value-based care lives in our value-based care world now. And these things lower medical costs, and that helps both the health of your patient population, but also the health of your health center as well. That's good for everyone, right? Healthy FQHCs and healthy patients. Wow, couldn't ask for more. Just sunshine and 4 weeks of vacation a year, and we're happy. Um, in the past 2 months, have you skipped meals? Yes. Ooh, red flag. First one. Are you homeless or worried that you might be in the future? Someone mentioned current housing. Diego nailed it. Diego, you said you were coming from Massachusetts. Where are you coming from?
I'm in Worcester, Massachusetts. Edward Kennedy.
Diego, you're unmuted. What do you do in Massachusetts? And are you going to go help make those main beaches crowded this year?
Yeah, I'm in Worcester. Can you hear me?
Yeah, well, I can hear you a little bit. You're in
Okay.
Worcester. Okay,
Yes.
lovely.
Worcester, Massachusetts. Yeah, I kind of mentioned housing because of all the factors. Like he was missing appointments. Also he missed appointments. He missed picking up his. Yeah. So I mentioned that because if you can't get to your appointment or you can't, if you don't have housing, he lost 67 pounds. Could have been that he couldn't eat because he didn't have food.
Yeah, 100%. So you nailed it, and you were ahead of us there. So I think you read my case study beforehand. What do you do out there in Worcester again? Could you tell me again, please?
Yep, I do the population health outreach for the C3.
Okay, fabulous. So you're the guy who does this stuff, 100%. And you're right on. So we're trying, and thank you very much for sharing and for doing what you do. But I want to emphasize something that you mentioned, and it's about priority. So, oh, thank you. Judy added a screening talking point guide for us. Thank you for that. Um, good. Let's help our colleagues. We're all in this together. But to focus on the housing for a moment there. Well, this guy's not showing up at his appointments, and sometimes when we see a patient that's not doing their screening, they're not showing up to their primary care appointments. Our knee-jerk reaction can be, they're not taking this seriously. Why should I take it seriously? Real thoughts that go through people's heads, right? Especially when you're working 60 hours a week and you're seeing 30 people like this. It can be frustrating. But it's important to emphasize what real life priorities are for real life people. And if you are intermittently homeless or you don't have housing and you're not eating full meals, is getting your colonoscopy a priority? What do you think, Fide?
Not at all.
No, no.
Mm-mm.
So sometimes for someone like Mr. Rossi, the fix might be helping him with his housing. The fix might be helping him with his medication. The fix might be helping him with his meals. If he is well fed and he is sleeping in a bed, he's going to have some time to think about things, and he's going to have some time to think about things beyond what day-to-day needs are. When we support people like that, we allow them it changes their life completely. For those of us who have worked with unhoused people or have been unhoused ourselves before, it is incredibly stressful. You are living minute to minute, in many cases. And it is unfair for us to expect a patient like that to be on top of all of their housing, all of their screening. So when we assist the patients and provide them with network them to resources, provide them to resources, we give them the leg up. Because if you're going to do your screening, you're going to do it because you're motivated. And you're going to be motivated to take care of those things if you can think about them. And it's very difficult to think about these things if you're worried about what you're going to eat tonight. So good point. Thanks for doing that, what you do, and thanks for mentioning that. So he mentioned issues with utilities as well. And here's another big one. He can't find a ride. Okay. Maybe when I just said that I was frustrated with this patient for not coming in, and you think of it, you see a guy that comes in, he's cachectic, he's lost weight, you haven't seen him since 2024. It's frustrating to see patients like this, but that's often our knee-jerk reaction, not a one that's based on reality. If he's unhoused and he can't get a ride, it's very hard to do that. That's a barrier, and it's a barrier that's like a wall. So that's why we do this screening. And by that I mean the not the colorectal cancer screening, but the non-medical needs screening, because it is just so important because it tells us solutions to problems we didn't know we had. Um, he has no child care issues. Next slide. He's unemployed. Okay, well, I think we're finding the roots of things here. He has noted that he needs help finding a better job, or he's open to employment and so forth, or employment assistance. Not concerned about education, not concerned about someone at home using drugs or alcohol. He feels safe, no safety issues, and no one is threatening or abusing him. So we've got some serious red flags here.
Unsafe, Kevin.
Oh, I'm running out of time. Okay. Next time we are going to take this up and we're going to take Mr. Rossi. We are going to help him to fix his issues. And we're going to find out that he's very resistant to the idea of colorectal cancer screening. He does not like the word cancer, and he disappears again when we mention it. And we're going to have conversations about how to work with patients that react that way, how we react to that, how we typically do it, and how we can do it better. Thank you for joining. Thank you for serving who you serve. And have a lovely week. I'm looking forward to seeing all of you. From Maine to Oregon to Oklahoma, thanks for coming. We got the beautiful country. We've got people from all over the place. And keep serving your communities and go FQHCs. Thank you for your time.
Thank you. Thank you so much, Kevin, and thanks everybody who was able to participate in today's session as well. Just a kind reminder to please complete our post-evaluation and let us know how we did in our first session. That way we can also make any improvements in our future trainings. This is just our disclaimer. The mission of NCHPH is to strengthen the capacity of all health centers and health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by HRSA and did not necessarily represent the official views of the U.S. government. And here is our direct contact information. And thanks, everyone. We look forward to seeing you all next week. Have a wonderful day.